Greetings to you all, wherever you may be. We're back here again. This is the third of a series of lectures on hypertension and pregnancy. This lecture particularly is on preeclampsia and eclampsia. My name is Diana Wolfe, and I'm from Albert Einstein College of Medicine, where I am a subspecialist in maternal fetal medicine, and glad to be here. So, the learning objectives of this lecture is, first of all, to define preeclampsia and also to inform you that there has been a new definition for preeclampsia that's been proposed by the American College of OBGYN. Secondly, to understand the pathophysiology of disease and also to know the risk factors of disease. So preeclampsia, the traditional diagnosis was a combination of hypertension and proteinuria, that is urine in your protein. You must have mild blood pressure, that is systolic blood pressure above or equal to 140, and or diastolic blood pressure above or equal to 90 upon 2 occasions 4 hours apart with protein in the urine. That is 300 milligrams of urine protein over a 24-hour period if you collect urine for 24 hours, or on a dipstick, 1+. Now, actually, 1+ is incorrect. 300 milligrams is actually 3+. So 1+ is really equal to 100 milligrams per deciliter. Severe hypertension is systolic above 160 and or diastolic above 110. We mentioned that in the previous lecture. So the American College of OBGYN in November of 2013 proposed, their task force has redefined the definition of preeclampsia. So their proteinuria definition, the blood pressure definition has not changed. What we mentioned on the previous slide is you can have a mild range of blood pressure, but you have to have it on 2 occasions, 4 hours apart, or a severe range pressure even just once to meet the blood pressure criteria. Now, the task force is saying that if you have proteinuria, even a dipstick reading of +1, or a protein creatinine ratio of 0.3, or greater than or equal to 300 milligrams in a 24-hour period meets criteria for proteinuria. But what's new is that you don't need to have proteinuria to have preeclampsia. If you have a platelet count of less than 100,000 per microliter, or if you have creatinine that's greater than 1.1 milligrams per deciliter, or double the previous value, or if you have elevated liver transaminases to twice what's normal, or pulmonary edema, or cerebral symptoms, you have a patient with preeclampsia. I hope that's clear. We'll say it again in a different part of the presentation. Now this is a slide on the traditional diagnosis of severe preeclampsia. We already talked about the blood pressure criteria. The traditional proteinuria criteria was, like I said before, greater than or equal to a 3+ urine protein on a urine dip, or 5 milligrams of protein in 24 hours. So those two, the blood pressure and protein, with a platelet count below 100,000 cells per milliliter, abnormal liver function testing, maternal oliguria, maternal pulmonary edema, epigastric pain, and cerebral or visual disturbances. Now, I'm just defining to you today both the traditional and the new diagnosis, because wherever you are, you may have access to a urine dipstick, but not to a creatinine ratio. So I want you to have multiple tools to help you and your facility make the appropriate diagnosis. Now, the new diagnosis this is the ACOG task force from November 2013. They describe preeclampsia with severe features, including a platelet count of less than 100,000 cells per microliter, creatinine of greater than 1.1 mg per deciliter, or double the previous value, elevated liver transaminases to twice normal, pulmonary edema, and cerebral symptoms. So, not to confuse you too much, basically, the task force is proposing blood pressure with proteinuria, blood pressure without proteinuria, but with some severe features, all equals preeclampsia. So what is preeclampsia? We hear it all the time as OBGYN residents. What is it? There's a cascade of events that leads to the syndrome, and there's been many theories that have been proposed. What has been proposed is that there's a vascular endothelial damage, and then there's vasospasm and transudation of the plasma, leading to ischemic and thrombotic sequelae that affect both mom and baby. These are some theories proposed by Dr. Sabai, who is an academic professor in our country who has wrote many publications, which you may have already read and know of, on preeclampsia. He proposes abnormal trophoblastic invasion of the uterine vessels at the very beginning of pregnancy. Another cause could be immunological intolerance between maternal and fetal-placental tissues. Another is maternal maladaptation to cardiovascular or inflammatory changes of a normal pregnancy. Another possibility is dietary deficiency. And lastly, genetic influences. But we don't really know whether this disease has multiple causes and multiple pathways, or if there's just one or two. But what we do know is we know how to diagnose it, and we know how to manage it, which will be a separate lecture. So, incomplete trophoblastic invasion, well, how does that happen? Normally, in a normal pregnancy, you have uterine spiral arteries that undergo extensive remodeling, and they are invaded by the endovascular trophoblasts. In preeclampsia, it is thought that there's an incomplete trophoblastic invasion. The decidual vessels, not the myometrial vessels, become lined with endovascular trophoblasts. And this has been seen under the microscope in preeclamptic patients. So this is a schematic of what I've just described. You can see there's two different spiral arteries. The one on the left shows the spiral artery invading the decidua. And on the right side, there is proliferative extravillous trophoblast in the cell column, and the artery has vasospasm, so it looks very different in preeclampsia. You can see here again in the normal placentation, you see that it depicts the placental side and the maternal side, and you can see that the spiral artery is pleasantly placed there. You have your cytotrophoblasts sitting in the decidua. On the right side, you have abnormal placentation. You have the spiral artery and the decidua part is being invaded by macrophages, and your intervillous space is narrowing. So early preeclamptic changes, there's endothelial damage, there's insinuation of plasma constituents into vessel walls, there's proliferation of the myointimal cells. Lipid accumulates first in the myointimal cells and then in the macrophages. This is called atherosis. Sounds like atherosclerosis because it's very similar, but it's in a spiral artery of a pregnant woman, so it has a different name. Then comes the obstruction of the spiral arteriolar lumen by atherosis, which may impair placental blood flow, and this leads to medial necrosis. So look at this. This is a cross-section under the microscope. You can see the cartoon to the right. This is a cross-section of your spiral artery. Look at this. You have a lumen, and you have these endothelial cells, which are disrupted. And then you have lipid-laden macrophages and fibrin plasma protein that are embedded in the fibrin plasma protein. So this is a terrible disease. Immunological factors. Preeclampsia develops left often in multiparous women. Multiparous women impregnated by a new consort, by a new partner. There's a decrease in proportion of helper T cells compared to women who remain normotensive. And when we know that women with anti-cardiolipin antibodies that preeclampsia is much more common, and therefore they're at higher risk for the disease. The vasculopathy and the inflammatory changes include the decidua, which can release noxious agents. The placental factors are released by ischemic changes, and these then serve as mediators to provoke endothelial injury.